wonderful experience, actually. I never seen people asking this much doubts and this much clarity and this much understanding. This is excellent. And being a part of Fascia Research is now I feel is a big proud moment. Thank you for that one. So I'm working in Qatar, Hamad Medical Corporation, and basically root in India. So I started in research in myofascial release and have few RCTs. Then I thought, am I doing correct? Am I doing the perfect way? Whether I can improve my studies, my quality of RCTs? Then I thought I will do a critical appraisal of my own studies. And it was approved from the University of Bolton as a PhD, so that was my second PhD, graduated in July 2018. So my title is The Quality of Current Myofascial Release Research, where we are, critical appraisal findings of randomized controlled trials and a systematic review. So as you know, myofascial release is a form of manual therapy that involves the application of a low load, long duration stretch to the myofascial complex, intended to restore optimal length, decrease pain, and improve function. MFR is being used to treat the patients with a wide variety of conditions, but there is scarcity of evidence to support its efficacy. Now there is not scarcity, we are actually improving, collecting, gathering. So this critical appraisal, the objective is to critically appraise and summarize the quality of current myofascial release research by analyzing selected RCTs and systematic review of myofascial release on various neuromuscular conditions and pain. So the method, effectiveness of myofascial release on tension type headache, lateral epicondylitis, and chronic low back pain were the RCTs identified for this review, and there was one systematic review that's also published in 2014-2015. The methodological qualities of the studies were assessed using Pedro scale, Center for Evidence-Based CEBM scale, Cochrane risk of bias assessment, AMSTAT2. AMSTAT2 is for systematic review analysis. And this is actually called critical appraisal of one's own studies. The first RCT appraised was effectiveness of direct with indirect technique myofascial release and the management of tension type headache, which was published in Journal of Bodywork and Movement Therapies in October 2011. And the study actually enrolled 63 patients in 3 groups. One group is indirect technique myofascial release, second group direct technique myofascial release, and the third group a sham group. And the outcome measure was the frequency of headache per month by using headache diaries. And the study concluded that the study provides evidence that the direct technique and indirect technique myofascial release is more effective than the control intervention for tension headaches. The study didn't analyze which myofascial release is more effective. And the Pedro analysis revealed that the study is having a rate of 6 out of 10. Somebody says that it is moderate, somebody says that it is high. So our score is 6 out of 10. And level of evidence was actually level 2B RCT because the problem with the follow-up. And risk of bias, actually, we have found that there is lesser risk. But risk of found analysis was done by a blinded statistician. Limitations, lack of follow-up, lack of blinding of the therapist and the patient, no sample size calculation, usage of slow soft stroking as a sham. Like when we are touching, even keeping the hand, no body, there is changes happening. So is it sham? This is a big question. The next RCT is actually effectiveness of MFR in the management of lateral epicondylitis in computer professionals. That was published in 2012 in Archives of Physical Medicine and Rehabilitation. And there were 68 patients enrolled into 2 groups. One group was myofascial release, another group was sham. And the outcome measure was patient-rated tennis elbow evaluation. And concluded that MFR is more effective than a controlled intervention contains sham. The sham was sham ultrasound therapy. They removed the crystal from the ultrasound crystal, but doing the movement. So the score of this one was quite high. It was 7 out of 10 in Pedro scale. And CEBM, it is 1B minus RCT because there was follow-up. And risk of bias was lesser. And the limitation was short-term follow-up, lack of blinding of the therapist. Here, the patient was blinded, but therapist was not blinded. No sample size calculation still, usage of cyst as a sham because you are moving over the body. So is it really sham? And the third RCT was effectiveness of MFR in the management of chronic low back pain in nursing professionals. It was published again in Journal of Bodywork and Movement Therapies in 2014. And there was 80 patients enrolled in two groups. One is myofascial release with specific back exercise. Another is sham myofascial release with a specific back exercise. And the outcome measures used was McGill Pain Questionnaire and Quebec Back Pain Disability Index. And the conclusion was MFR, when used as an adjunct to specific back exercise, is more effective than a control intervention in chronic low back pain. And the score of this PEDRO score, for PEDRO means the quality, so we measure the quality, methodological quality. It is 7 out of 10. The CEBM here is level 1B because its confidence interval was narrow, and there was a follow-up, even though it is smaller. And LISCO bias was lesser. And limitations, short-term follow-up, lack of blinding of the therapist again, no sample size calculation, finger placement as a sham. Okay, when you're in sham MFR, they are placing the hand, and they're telling that this is the placebo or sham. So then we concluded, actually, what are the strengths and limitations. The RCTs analyzed in this study were moderate to high methodological quality, PEDRO scale according to, with a higher level of evidence according to CEBM scales, with fewer bias. So it's acceptable. Appreciable in their adherence to near normal RCT guidelines. The study actually done with most of the RCT guidelines. The allocation sequence was adequately generated by a blinded statistician by means of computer-generated randomization list. Blinding of the assessors for all RCTs, but again, practitioner blinding in manual therapy. There are a lot of debate happening whether you can really blind practitioner in a manual therapy. Even patient blinding itself is a big deal in manual therapy. If you are doing really practices, you can feel. So there are a lot of articles already there regarding the debate. The missing of outcome data and dropouts mentioned. This is less than 5% only. So whenever the study, we have to figure out how much is a dropout. If it is more than that, you have to go for some intention to treat analysis to have the exact effect. So another problem was usage of patient-rated outcome measures. Is it a strength or limitation? So Kate actually saying that high-quality clinical care requires patients to provide information regarding how they are feeling, their symptoms, and affects the prescribed treatment. And wording added that disease-specific PROM, that is all patient-rated outcome measures, are more idealistic as primary outcome measures as they have greater face validity and credibility than generic PROMs. Actually, PROMs are always patient-centric. You will get more quality type of assessments. But the problem is recall bias. Patient forgets many things. So that is the problem with PROM, is the recall bias. Details about the expertise, experience of the practitioners are mentioned in almost all these three studies. Usage of protocol-based treatment was used. Everything is a protocol-based. Effect in the control group mentioned as meaning response. So here, the others actually mentioned that there is a change in the control group also that is like a meaning response. I think in the later session, we can discuss about meaning response. No attempted effect size calculation, but only confidence interval. So nowadays, studies are asking for effect size calculation to know the clinical significance. And there is only one systematic review that was analyzed on effectiveness of MFR on 2015. This systematic review is analyzed RCTs. There was 19 RCTs at the end of that selection. And the quality of the systematic review was assessed with AMSTAR 2 tool. AMSTAR 2 is the latest version of AMSTAR 1. And they found that it is a moderate methodological quality. Why it is moderate methodological quality? You can see that most of the studies in the PEDRO actually having scores 6 to 8. That means the methodological qualities of the studies of current RCTs in MFR is okay. But if you are seeing the CEBM scale, you can see that most of the studies are in 2B. 2B means low quality RCTs, or there is RCTs having problem with follow-ups or confidence intervals or sample size. Only few studies are actually having high quality RCT. So this is the area we have to think about to improve ourselves to have more high quality RCTs. And strength and limitation of the systematic review, clear inclusion and exclusion criteria and a sensitive search strategy was there. Trials were assessed for quality using recognized critical appraisal tools like PEDRO, CEBM. And the AMSTA-2 analysis revealed that the systematic review is a moderate methodological quality. Why it is moderate? Because the systematic review never done a risk of bias analysis. So when you are doing a systematic review, go for any type of risk of bias analysis. Then comprehensive research strategy only go partially yes, because we didn't include articles in press and gray literatures. And no details about excluded studies. The current systematic review asks for details of studies you have excluded. Due to the high level of data heterogeneity and underpowered sample size within trials, of course, there will be high chance of type 1 error. Generalization of the result was almost impossible. If you have small group studies, generalization will be the problem. Heterogeneity in the treatments administered, actually it's a common problem with manual therapy and intervention. I am doing in a different way, you are doing a different way. So generalization of the treatment, it's always a problem with manual therapy. Possibility of super realization bias due to smaller sample size. When you are doing a small sample size study, you can do more controlled study. That will give more actually positive bias. You are doing something, but you cannot get that one if you are doing a good big sample study. So that is called a super realization bias. So most of the studies what we are having actually, there is a super realization bias. No information regarding the degree of agreement between the two independent reviewers. And the study highlighted that the magnitude of effect were mostly retained in studies with follow-ups, even though such studies were less in number. And the systematic review ends with a justifiable conclusion that MFR alone or added to another conventional therapies relieves pain and improves function, not less than conventional therapies. Overall, this systematic review is recommendable as a starting point for assessing the quality and variety of available evidence on the efficacy of MFR. To conclude, we are having a recommendation. Always go for a priori calculated sample size with adequate power, a well-planned and methodologically sound protocol with a statistician support from the beginning give you good study. Reliable and validated outcome measures, always use it, limiting the source of bias as much as possible. Follow-up time point beyond 24 hours. Assessing the threats of statistical validity and appropriate registration. Should present between group differences, that is complete with the confidence interval and effect sizes, and avoid reporting within group differences as evidence of effectiveness. Controlling the intrinsic and extrinsic factors to the maximum possible level. Studying the effectiveness of myofascial release as a single therapy and comparing it with a control, no treatment group, and with other established treatments, different type of comparisons. This analysis supports many of the norms put forward by the systematic review team and believes that such attempts will make the research in manual therapy field more valid and reliable. To conclude, critical appraisal is an important element of evidence-based medicine to carefully and systematically examine research to judge its trustworthiness, value, and relevance in a particular context. This analysis concludes that the RCTs and systematic review analyzed in this review had the potential to move the myofascial release research into the next level, though the methodological flaws and interpretation biases are evident. The authors are hopeful that this type of critical analysis can act as a permanence on which high-quality future MFR trials and evidences can build on. Thank you for your time, and these are the references. And
okay. Are there any questions in regard? Okay.
Pardon?
Hello.
One second. Yeah.
Hello, thank you for the talk. First, just want to celebrate your work and also what it represents. 11 years ago at the first Congress, we were nowhere near the volume of evidence where we could start aggregating that evidence and evaluating the methods and sorting out our weaknesses and our conclusions. So just your work specifically, but also what it represents for this field of inquiry is just really impressive, and it makes me very happy.
Thank you.
And I'm just curious where you see this in another 10 years. You know, you listed a lot of obstacles, but in your fantasy world, you know, what would 10 years hence be in terms of the state of the evidence?
Yeah, that's a good, actually, questions. Always we used to think what we will be after 10 years, because the fascia is getting so complicated nowadays. It's, actually, that is the word we had to use. It's more complicated. We are trying to define fascia by means of physics, by means of biology, by means of neurophysiology, but at the end of the day, fascia remains as a miracle. So Dr. Paul has given some dose-response studies. Actually, that's our future. But where we are starting at that point and where it has to be gone, still a big question. Because fascia starts from the cellular level, rounding, and reaching the periphery. So when you are treating, as another delegate says, hitting a particular area, you cannot even isolate that it is fascia. You are actually releasing the fascia, the muscles, and there. So to be more specific to that fascia, how we can analyze and make sure that we are actually releasing the fascia, how we can isolate the fascia superficially, deeply. These are all areas we need more technical research, innovative research. Then we need this type of dose-response studies translating into the clinical practice. So the question is, I'm bouncing back to you. Still no idea after 10 years where we'll be in the fascia.
Other question? We can go ahead with the next presentation.
Thank you.
Thanks a lot. I have a simple question for Rashid. May I ask you? So, when we get, what is really the process to get level 1, 2 of evidence of the technique works? So, I know that the review is amazing, it's very important, but do we need to publish in Cochrane? What is really the requirement to say, yes, now we have evidence?
Yeah, that's actually an excellent question, basically. How to improve our study and how to state that, like my fascial release having an evidence, you can say 100% that there is an effect. So how this goes level 1, level 2, level 3? Of course, the level 1 is a good quality systematic review will be in level 1. You know the problem with myofascial release, because the practice is so different, practice variations are there. The concept itself, if you are seeing the previous declaration, they used, I think, facial manipulation, direct technique myofascials, indirect technique myofascials. So we have to define faster ourselves what we are going to use. This is very important. So at this stage, conducting a meta-analysis for myofascial release is almost impossible. Otherwise, you will have 1 or 2, and the result will be limited. You cannot generalize it again. So we have to go for all these rules, like go for the sample size calculation, that is most important. Avoid all the superrealization biases, and just make it a protocol-based. Both are acceptable, protocol and variation. Like some practices uses, okay, today I found this much change, I'll go for next level. So these both are accepted according to the concepts of manual therapy. But if you are able to do a systematic review with all the ethics of systematic review, that can be calculated as level 1. Because meta-analysis till now is beyond our calculation. If meta-analysis is Cochrane, almost same, but meta-analysis at this point of time, I believe that you can include only because the heterogeneity is solved. Almost all homogeneity test will be failure if you are doing a homogeneity test to find out which are the studies you can calculate. Wait for a while, as he said, maybe future years you'll have more standardized trials, more standardized RCTs, level 1B RCT, that can be used for meta-analysis proof that myofascial release is level 1 care. So I think that gives the answer. So level 1 is meta-analysis, typically Cochrane, but we don't currently cannot able to do that one. Go for systematic review. High quality systematic review is still level 1, level 1A actually. Level 1B is high quality RCT. It should have sample size, it should have lesser bias, it should have a narrow confidence interval, it should have clinical significance. So all the sort of things, if it is there, it will be a good, with a good follow-up. That is very important. Most of our studies we found is actually doesn't have follow-ups. So this is the time to start doing follow-ups. So that is very important. So if these criteria are there, almost our studies will go to 1B RCT. Once it is in 1B RCT in your hand, things will be easy. There will be a lot of people, they can do the meta-analysis for us, even Cochrane studies.
Thanks for the answer, very appropriate. And I hope that help also other people to approach the research and to move on and to see that these data are necessary for everybody.
So I'm going to be very provocative as usual. I'm going to ask each of our speakers to give me about 3 sentences on the most appropriate sham, the most appropriate control for any study that involves hands-on manipulation. So since you're at the microphone and you did a meta-analysis, just 2 or 3 sentences so that we can hear from each of our speakers. And it's easy to do it in bioengineered tendons. I just ignore them and their feelings aren't hurt, but.
So what is the ideal sham? For me, don't touch the patient if ethics allows. But ethics never allows, you cannot touch the patient. So waiting list. So otherwise, most of the sham will be having effect. You know, the meaning response point goes, you are giving paracetamol to patient A, no label. You are giving the same paracetamol patient B, which is a branded one. The studies are saying that the branded paracetamol gives more effect. So this is what is called a meaning response. So when meaning response, we are telling sham is having an effect. Even you are telling that, you will be okay. It makes a change.
Yeah, but may I tell you? The patient, the bias of the patient, so a patient will now be blind if you don't touch the patient. So it would be difficult to have an answer, but let's try.
Yeah. Yes. So
I want to explain that also if you have 2 degrees of blindness, you know, it's still a good study. So if the statistician have a blindness, you know, the patient have a degree of blindness, we know the therapy, manual therapy is difficult to generate a blindness. So it's still a good study, so don't be afraid. You can move on. You can organize a study. You can do it. We will need it for the next Fascia Congress. So I think yeah.
because of it's a good study. Nowadays, I believe, that's my opinion, I just want to share it. I think we value too much randomized controlled trials, and there are other kind of studies that are very useful as well, because sometimes we control so much the variables that it's so aseptic condition environment that then there's nothing similar with our patients who have lots of conditions. So sometimes we control it so much that it's not representative of our population. So I have a kind of, you know, I think some of you might share my opinion. We need to be a little careful with this devotion to RCTs.
So that, what Anna is telling is true. But the thing is that how this research goes, the basic research, basic biological researches, like the translational studies. The 2010, there is a study proving that myofascial release causes like changes in apoptosis and proliferation changes and all. That was something which is can be translated into RCTs. For example, when you are having studies, dose response, translational studies, basic biological and basic studies, use that one, explain that for your effect on that one, and it has to go to the RCT. Of course, we know that conducting a high quality RCT is very difficult, but when we are considering whole healthcare system, it goes in that way. So it is not impossible, but it's difficult. Because one statement always says that pooling of data from small RCTs is never a substitute for a good quality RCT. So this is always we are encountering when we are doing a systematic review. So we had to be like balanced, as she thought. Thank you.
Yeah. Well, we have to thanks twice the presenter. Once because they presented data for all of us to try to, prove what we are doing, and also a good news for you that with their study, clinical study, you have a simple side to start, because when it's time to decide what is the simple side, if you can prefer a previous study, it makes much easier and much simpler to define. So thanks twice, and thanks to everybody for being here until the end.